Okay, let's unpack this. Have you ever wondered what truly drives people to seek medical care beyond just, feeling sick? Or how we even begin to define what equitable healthcare access really means?
Yeah, it's a really complex question. And for this deep dive, we're going to explore foundational framework. It's really shaped our understanding. Ronald M. Andersen's behavioral model of health services use.
Right. And this deep dive is custom tailored for you, our listeners.
Mm.
We're drawing from his pivotal 1995 paper, Revisiting the Behavioral Model and Access to Medical Care. Doesn't matter.
Mm.
So our mission today is to pull out the most important insights from this model, this evolving model, understand its core parts, and see how it helps us analyze and maybe even improve access to care.
Exactly. Where should we start? The beginning.
Yeah, let's peel back the layers. Start with Andersen's original breakdown from the 1960s. He had these three key categories explaining why people use health services.
Okay.
First up, predisposing characteristics. This is basically who you are and what you believe.
So like demographic stuff.
Yeah, think age, gender, social things like your education, job, ethnicity, but also your personal health beliefs, your attitudes. These things kind of set the stage, surprisingly.
Okay, so that's the predisposition. What else?
Then came enabling resources. This is the practical side of things.
Ah, the how.
Exactly.
Yeah.
The means to actually get care. We're talking community resources like, are there enough doctors and clinics around? And personal resources income, health insurance. Can you get there? Transport. Do you have a regular source of care?
Got it. So the practical tools and supports. Or the lack thereof.
Right. And the third piece is need.
Need. Okay, that sounds obvious, but I bet there's a twist.
Well, yeah. It's not just what a doctor says you need, the evaluated need. It's also your own perception of your illness, the perceived need.
Ah, interesting. So how sick you feel matters just as much sometimes.
Exactly. The model really acknowledges that sometimes, that gut feeling I'm not well is a powerful driver, maybe just as much as a clinical diagnosis. It's subjective and objective.
And the genius, I think, was putting these three predisposing, enabling, need together to see the whole picture, not just what services people use, but the why.
Right. And the goal was always tied to understanding equitable access. But you mentioned it wasn't static.
No, definitely not. It evolved.
So that was the foundation.
Right.
But healthcare changes, right?
Huh.
So Andersen's thinking evolved too. What came next? What were the big shifts in later phases?
Well, the model had to adapt. In the 70s, Phase 2 explicitly brought in the healthcare system itself.
Bigger picture.
Yeah, national policies, how resources are allocated, the very organization of care. It acknowledged that the system has this massive influence, and it also added consumer satisfaction.
Patient experience. Important.
Very. Then, moving into the 80s and 90s, Phase 3 brought in things even more.
How so?
It introduced health status outcomes, thinking about health as an outcome of care, both how the patient felt, perceived health, and the clinically evaluated health.
Yeah, makes sense.
And crucially, it recognized the external environment, things like the physical place you live, the political climate, economic conditions, plus personal health practices.
Like diet, exercise, smoking.
All these things interact with formal health services. It's not happening in a vacuum.
So it gets much more complex, acknowledging all these interacting forces.
Definitely. Which brings up a really important point. How does this model actually help us measure access? Is access fair?
Right. How do we define fair using this?
Well, the model gives us some useful terms. Potential access, that just means the resources are available. There's a clinic nearby, or you technically have insurance.
And it's possible to get care.
Right. Then there's realized access. That's the actual use of services. Did you go?
Okay.
But here's the key for fairness. Equitable access. That's when your use of services is mainly driven by your need, your health status, maybe some basic demographic factors.
And inequitable.
Inequitable access is when other things dominate unfairly, like your social position, your income, maybe your beliefs, or just not having the enabling resources. Those become the main reasons you do or don't get care, regardless of need.
That distinction is crucial. And it does raise that tricky question, like you mentioned, about context. The paper gives that example.
Yeah, the maternal and child health versus cosmetic surgery one.
Right. Income being a barrier to seeing a doctor when you're pregnant. That feels inequitable. But income determining if you get cosmetic surgery, maybe society sees that differently.
Exactly. It forces us to be explicit about our values, and that leads right into policy. How can we change things? The model introduces mutability.
Mutability.
Changeability.
Pretty much. How easy is it to change a factor through policy? Demographics, like age, low mutability.
Hmm.
You can't really change that with the law to affect healthcare use directly.
Okay.
But enabling resources. Some have high mutability. Think health insurance benefits or funding for community clinics.
Hmm.
Policy can directly tweak those to impact who gets care. That's powerful.
Hmm.
So policy should target the mutable factors that cause inequity.
That's the idea. Even things like perceived need can be influenced, right, through health education campaigns, or evaluated need through change in clinical practice guidelines.
And it keeps evolving, you said. Phase 4.
Yeah, the emerging thinking includes these dynamic feedback loops, like how getting care and improving your health status might then change your future needs or even predisposing factors over time. It's a living framework.
It really sounds like it.
And Andersen, in the paper, really stresses why this work is still so relevant.
Yeah.
Healthcare is huge. It's growing. Understanding equity, efficiency, like the health gain you get for the services used, and effective access.
Meaning, does using the service actually improve health?
Precisely. These are critical questions, and he argues sociologists have a really important role to play here.
So bringing it all together, what's the big takeaway? We've gone from a dissertation idea in the 60s to this really comprehensive, dynamic model.
I think the takeaway is that Andersen's behavioral model gives us this incredibly useful lens. It helps understand that complex dance between us as individuals, our background, our resources, our needs, and the huge system around us.
It moves us beyond just asking who uses what service.
Yeah, it pushes us towards deeper questions. Is it equitable? Is it efficient? Is it actually effective in making people healthier?
So a final thought for you, our listeners, as you think about healthcare around you, based on this model, what factors do you think are the most mutable, the most changeable by policy to create more equitable access? And what does truly effective access look like in the real world?
Good questions to ponder.
Definitely something to mull over until our next deep dive.